Hello everyone. So today's topic is intracranial complications of CSOM. So we will start by drawing a diagram. Okay. So this is our mastoid and this is a roof of mastoid. The other name for roof of mastoid is tegmen entri. So this is our tegmen entri, the roof of mastoid, and this is our mastoid cavity. Okay. So as all, and let's draw a part of brain above it. Okay, so this is our cerebral cortex. Okay, outer part, and this is a pia, the meningeal layer that is almost adherent to the cerebral cortex. And then we have arachnoid, and then our pia, sorry, then the dura. Okay, and so let's start understanding the complication. So the first complication we are going to talk about is when, as we all know, that CSOM can lead to an acute mastoiditis. That is an extracranial complication and one of the most common one. Now this acute mastoiditis, this inflammation can erode the roof of the mastoid cavity, that is tegmen entri, and because of this the infection can reach intracranially. And when this intracranial infection lies between this bone and the dura, this is known as extraduralapses. Extradural abscess. Now, what this extradural abscess do is it is the silent complication. Okay, this complication is a silent complication, means the patient generally are they are found incidentally when the investigation is done for some other cause. Now, other thing that can happen is the abscess can be present between the dura and the arachnoid. In this case, it is the subdural abscess. Now, this is the rarest complication of intracranial CSOM complications. Other thing is the infection can be present subarachnoid, and in that case there will be meningitis. Now, this is the most common complication of CSOM intracranially, and in this case the organism that is most common causative agent is streptococcus pneumoniae. The second most common is haemophilus influenza. Okay, so the patient of meningitis will present with fever, high grade, acute in origin. He will have neck stiffness and a classical two signs as you are seeing in this image. So the patient will show kerning sign, means on 90-degree flexion of hip as well as knee there will be pain when we extend the knee in this from this position. The other sign is Brudzinski sign, where on the till when we lift up the head while the patient is in supine position, the hip and the knee joint undergo a flexion. So this is what is meningitis. While treating meningitis, we have to give IV antibiotics, and for diagnosis we use lumbar puncture. The other complication and the second most complication is the brain abscess. Now, brain abscess resulting from a complication of CSOM can occur in two places. Either it can involve the temporal lobe, okay, located above the tegmen entri, or posteriorly it can involve our cerebellum. Okay, so a patient with a brain abscess from temporal lobe can present with nominal aphasia. Okay, means he will have difficulty in speaking normal word. He can have a vision difficulty that will be pie in the sky appearance. And the third thing is the patient can have convulsions, and this convulsions will be because of involvement of uncinate lobe. When cerebellum is involved, the patient will have ataxia, okay, dysmetria, and dysdiadokinesia and other symptoms related to cerebellar involvement. So these were the four complications. Let's move further and let's try to understand what will happen if the erosion occurs from the posterior wall of mastoid. Now, as we all know, the posterior wall of mastoid separates the mastoid cavity from sigmoid sinus, and this is what we are trying to draw, the sigmoid sinus. So here we have drawn sigmoid sinus. If erosion from the infection result in infection going into the perisinus space posteriorly, this infection, what it will lead to, it will cause damage to the intima of sigmoid sinus, and this will activate a coagulation cascade and leading to a thrombus formation within our sigmoid sinus. Okay, now what this thrombus will do is it can lead to result in emboli formation, and these emboli can go systemically, and when they reach in our systemic circulation they cause a spike of fever. Okay, and this spike of fever seen resulting from emboli in systemic circulation is what is known as hectic fever or picket fence fever. Okay, the other thing these emboli can result is there is an mastoid emissary vein that is draining our mastoid cavity as well as the post-auricular surface over the mastoid. Now, when emboli obstruct this mastoid emissary vein, drainage from the post-auricular surface of the mastoid is stopped, and this result in edema over the mastoid. And this sign is what is known as Grisinger's sign. Grisinger sign. The other thing this emboli can lead is thus, as we all know, the sigmoid sinus is going to continue as our internal jugular vein as it passes through our jugular foramen. Now, when this emboli obstructs our internal jugular vein, what we will see is patient will present as tenderness over neck in the region of internal jugular vein. What other things we will notice is this jugular vein will become non-functional and the other jugular vein that is normal will take its function. Now, when we try to check by compressing this jugular vein, what we will see is the non-functional jugular vein, that is the one with emboli, will not cause any change in intracranial pressure, whereas on compression of a normal jugular vein we will see a rise in intracranial pressure, and this said test is what is known as Tobey air test. Okay, and the last thing we need to know is that this emboli, this test can be also done by compressing the jugular vein and looking by fundoscope over the eye. A papilledema or will will signify that there is a rise in intracranial pressure, and this will happen on compression of a normal jugular vein, whereas on compression of this jugular vein with an thrombus emboli there will be no change, no papilledema seen, and this is what is known as Crowback sign. So these were some important intracranial complications of CSOM. One more thing we need to know is that, as we all know, the sigmoid sinus was the continuation of transverse sinus. Now this emboli can also go there and obstruct the drainage of our meninges, and this can result in impairment of venous outflow, and this will increase intracranial pressure again, and this condition is what is known as pseudotumor cerebri or idiopathic intracranial hypertension. So these were some complications seen in the case of CSOM intracranially. Okay, let's revise them very quick. So we have extradural abscess, that is also known as epidural or peridural, and this is a silent complication. We have subdural, that is the rarest of them complication. Meningitis the most common. Brain abscess the second most common. Temporal abscess presenting with nominal aphasia, pie in the sky, that is supranasal quadrantanopia, and seizures or convulsions. We have cerebral abscess with features of cerebellar involvement, sorry. We can have lateral sinus or sigmoid sinus thrombosis that presents with hectic fever, also known as PFC, the Grisinger sign on mastoid emissary vein embolism, the Tobbe-Ayer sign or Quickenstedt's test, and the Crowbeck sign. Another complication is aortic hydrocephalus, also known as idiopathic intracranial hypertension or pseudotumor cerebri. Thanks for watching.